Catalyst 2030 started life as a WhatsApp group among social entrepreneurs, connecting to envision real transformational change. Launched at the World Economic Forum in January 2020, it's grown into a global movement accelerating change to ensure the SDGs are reached by 2030. Fueled by passion, our 550 members working in 175 countries have collectively put in an amazing 50,000 volunteer hours, touching the lives of 2 billion people. And we're driven by values, to which we hold ourselves accountable. 2020 was a busy year, co-creating 3 reports with partners and producing one of our own. Inviting high-level guests to participate in the Catalyzing Change campaign, hosting fireside chats and expert hours, which will be continuing in 2021. To celebrate our achievements, together we placed our supporters in the limelight with the first Catalyst 2030 Awards for Systemic Change. With the blessing of the Dalai Lama, we celebrated finalists and winners in the following categories: special recognition for our early supporters, individual philanthropists, donor organizations, philanthropic intermediaries, corporate organizations, bi- and multilateral organizations, and 4 regional winners in the category of national governments. And now on to Catalyzing Change Week 2021. During this social entrepreneur-led event, we bring together diverse stakeholders in over 100 sessions to showcase their systems change efforts and the best practices that can accelerate our work in pursuit of the SDGs.
Thank you so much for that, Ben. We'll take it on from here. First of all, a very warm welcome to all of you. My name is Shri Rupa Sen-Gupta. I am here as your host facilitator for this storytelling session. Thank you so much for being here and joining us for this session. This is something which we're doing in incredibly trying times, and I am so grateful for you for coming and joining us here. Also, a big shout out to Catalyst 2030 for having us here. Just a quick request, if all of you could come on video, it would be phenomenal, because this is a storytelling session and it would be great to see you guys as we speak to you. So for those of you who have already switched on your videos, thank you so much. And we are just going to get started right now. The stories that we share today are important stepping stones to learning in making health and well-being real for the most poor and marginalized communities. Communities who, as we are seeing now, are most vulnerable to COVID-19. This is going to be about PHC exemplars that we can learn from to kind of, go towards our aim of universal healthcare and achieve it, and taking it all to the last mile. So today we're going to listen to certain stories, but before I go there, I am just going to request Ben to play a video for you. And this is a story that I would like you to watch. Go for it, Ben.
मेरा नाम निशा है, बेंगलुरु में हूँ। मैं फिश टैंक का जाल का जैसा घर में सीती रहती हूँ। मेरे 2 बच्चे ही, हमारे यजमान ऑटो ड्राइवर का काम कर रही। पहले तो बहुत प्रॉब्लम था, बीमारियाँ भी थे और आपको पैसा का भी प्रॉब्लम था। कैसा हमें ये सेविंग करने के बारे में मालूम नहीं था। कितना भी लाखों दिए तो पूरा खर्च कर डालते थे हमें। वो खर्च करने से हमें क्या भी बेनिफिट नहीं मिलता था। हमारे फ्रेंड्स जबीना ताज, यास्मीन, 2 जने भी फ्रेंड्स हमारे I4 के बारे में हमारा जबीना ताज बताए थे, जिसमें जमने से तुमना सेविंग का भी होता है दीदी कर को उन्होंने बोले। वो होंगे हम जमते ही हमें उसमें कर को बोलने में जमा लिए। पहले में बहुत वाखा था रहता है, मतलब वो कैसा पैसा बचाना मालूम नहीं था। अभी इसमें जमने के बाद पैसा ऐसा बचाना है करने का वो रास्ता हमने दिखाए। और आपको हेल्थ का पहले ज़्यादा बीमारियां आते थे, अब वो नहीं है। उसमें हमें वो पैसा भी हम ना बच रहे। अम्मी का हंकी का वो फुल ब्लैक हो गया था हंकी, उधर जमने से उन्होंने ब्लालक जगह उधर ऑपरेशन करे थे.
ஜெபினா சொன்னாங்க, இந்த சங்கத்தில் சேர்ந்துங்க நல்லதாகுது எது ஒன்றும் அப்படின்னு, அதனால் சேர்ந்தோம். இப்போ எனக்கு கண்ணுக்கு ஆப்ரேஷன் பண்ணாங்க, நல்லதே நடக்குது எனக்கு.
ನಮ್ಮ ಹೆಂಗಸರು ಇಲ್ಲಿ ಶಾಪಲ್ಲಿ ಸೇರಿದ್ರು, ಇಲ್ಲಿ ಸಂಘದಲ್ಲಿ ಸೇರಿಬಿಟ್ಟು ಆದಮೇಲೆ ಅವರು ನಮ್ಮ ಮತ್ತೆ ಕರ್ಕೊಬಂದು ಇಲ್ಲಿ ತೋರಿಸಿದ್ರು. ಫಸ್ಟ್ ಅವರಿಗೆ ಆಪ್ರೇಷನ್ ಮಾಡಿ ಕ್ಲೀನಾಗಿ ಅವ್ರಿಗೆ ಅವ್ರ ವಾಸಿ ಆದಮೇಲೆ ನಾನು ಒಪ್ಕೊಂಡೆ. ಚೆಕಪ್ ಮಾಡಿಸಾದ್ಮೇಲೆ ಅವರು ನಾನು ಕೇಳಿದೆ, ಸರ್ ನನ್ನ ಹತ್ರ ದುಡ್ಡಿಲ್ಲ. ಬೇಡ ದುಡ್ಡಿದೇನು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ, ನಾವು ಫ್ರೀ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಿ ನಿಮಗೆ ನಾವು ಕಳಿಸ್ತೀವಿ ಬನ್ನಿ ಅಂತ ಹೇಳಿದ್ಮೇಲೆ ಚೆಕಪ್ ಮಾಡಿಸಿ ಆಮೇಲೆ ನಮಗೂ ಆಪ್ರೇಷನ್ ಮಾಡಿ ಕ್ಲೀನಾಗೆ ಚೆಕಪ್ ಇವಾಗೆಲ್ಲ ಪರವಾಗಿಲ್ಲ, क्लीनाಗಿ ಇವಾಗ ಚೆನ್ನಾಗಿ ಕಾಣಿಸ್ತಾ ಇದೆ.
फर्स्ट में ऑटो को ज़्यादा नहीं जाते थे, हंकी का प्रॉब्लम रहने से वारम में 2 दिन 3 दिन होता जाते. अब वारम भर जाते, एक दिन छुट्टी ले लेते हम ना जमने से क्या एक भी छोटा मोटा हम ना ये होने से हमें हंजा को दिखाती अच्छा हो रहा है. और को हमारे घर का भी हमें पाक साफ रखने का सब हमें अच्छा ये कर ले रही, पाक साफ रखने का सब उन्होंने बोल को देने से हमें अब अच्छे ही बच्चे भी क्या एक भी बीमारी नहीं क्या भी नहीं, उनको भी अच्छा है. अब हम आराम से हैं. अब
Thank you so much for that, Ben. So what is right now quite important for all of us to see is that for Nisha's story, right? Nisha and her family are among the most poor and marginalized communities in India. They live in an urban slum, and social determinants completely govern how their health and well-being is. Health and well-being at the end of the day are outcomes. And that is where innovations in primary healthcare can really make a difference. Now, when we talk about innovations in primary healthcare, that becomes extremely not only important, but also sometimes the critical deciding factor, the critical success factor that can take universal healthcare to the last mile. And that is the reason why we are here today. Nisha's story was just an example on how a community can really thrive when they experience innovations in primary healthcare. And now I'm going to introduce you to somebody who has been a very dear friend and mentor, but somebody who I completely admire for her achievements in the field of public health. Dr. Angela Chaudhary, she's the partner at Swasti and Catalyst Management Services. She's also the health lead in the COVID Action Collab. She is a qualified surgeon, a journalist, and a public health specialist. And she has been working to strengthen primary healthcare at the last mile for the last over 2 decades of her life. So over to you, Angela, welcoming you to the stage.
Thanks, Shree. I wasn't sure you were talking about me. Such tall words. Thank you very much. I'm touched. Hi, everyone. Welcome to this session. This is quite a difficult time, and it's really wonderful to see everyone here to champion the cause of primary healthcare solutions at such a grim time in India and a few other countries where everyone is touched one way or the other. I'm not going to speak extempore because I've penned down a few words, so apologies, but I'm going to be reading so I don't lose my thoughts here. Building a strong primary healthcare system is the first critical step towards universal healthcare. We need our first line of defense to be accessible and available to every single person throughout their life course, so that most don't need expensive care for preventable conditions that only push them further into poverty. We need healthcare for all, and we need it now. Primary healthcare, as opposed to other types of care, is well poised to respond to rapid economic and technological and demographic changes. It has been shown to be highly effective in addressing the main causes and risks for poor health and handling the emerging challenges that threatens this. It proves to be a good value investment as it reduces healthcare costs and improves efficiencies. A strong primary healthcare system is essential to achieving the SDGs and universal healthcare. In India, one of the main challenges facing us today is our large population with multiple burdens of ill health. We continue to face high costs, poor quality of care, and poor access. Despite these challenges, there are exemplars who've navigated these systemic and environmental challenges through innovations, grit, talent, and leadership. Swasti, a part of Catalyst 2030 and Health Systems Transformation Platform, got together to explore who these exemplars are, why they're exemplars, what made them tick, and what others can learn from them and adapt to their situations. Our team has been working for the past year to bring these primary healthcare exemplars to the fore so that we advocate for the best possible ways to build capacity and provide healthcare in resource-constrained contexts. We wanted to ensure that our efforts were people-centered, cross-sectoral, and that these solutions were equitable, empowering, and helped keep the system socially accountable. The idea of community-centric healthcare was the basis for the start of our project, A Systematic Review. We searched for primary healthcare innovations that have been published since 1990s, filtered it through a total of 241 innovations in each health system building block, and an advisory group consisting of the highest echelons of primary healthcare supported and endorsed those long list of exemplars. And the selected innovations and models were vetted with people working on the ground, ensured that we weren't only limited by publications in academic journals. The resulting models and innovations were developed as case studies through interviews of those who envisioned, designed, and implemented these programs. And these were written into some of the stories that we will be telling you today. One of the key things we learned from our endeavors is that no one primary health component or innovation makes or breaks a comprehensive model. It is the synergy of the different components, innovations, and intersections that create the magic of a well-functioning system. Innovations have been key in streamlining added services into primary health services. I hope you enjoy some of the narrations we have today. Over to you, Shree.
Thank you so much, Angela, for sharing that context. We are just now going to go into the next piece, all right? And this is where it becomes very important. And what I really wanted to share with you is that today we not only have the authors of these stories with us talking to you about all of this, but we also have the protagonists, the people who made these stories actually real, the people based on whom we have built these stories. So first on, I would like to welcome the first author that we have with us today. Her name is Radhika Jabria, and Radhika has been a phenomenal influence in my life as well. She's a social entrepreneur. She is an SR/HR specialist, and she has been working tirelessly on ground as well as at strategy and policy levels. Radhika is going to talk to us about POD adventures on games and well-being. Over to you, Radhika.
Thank you so much, Shree. It's truly an honor to be here today. Globally, individuals living with mental health disorders are more likely to have access to a mobile phone than mental health services. This statement stresses the need for digital innovations in mental health service delivery. While we're working to flatten the curve with COVID-19, there really has never been a better time to accelerate and bend the curve for digital health technologies. And Sangat's POD Adventures is one such innovation that uses a hybrid approach to scale mental health innovations in low resource settings. I'd like to start off today's presentation by talking about a story that's very dear to me. Hasina was a student in a class that I taught for 2 years in a slum in Jogeshwari. Hasina's attendance was patchy, to say the least. And as a teacher, I was concerned about the impact this would have on her academic as well as emotional well-being. So on one of those days when she happened to be in school, I caught her and I sat with her and I tried to understand what the root of the problem was. Hasina was born with a cleft lip, and this often left her vulnerable to being bullied and or not just by her students, but also within the community and on her way to school. And she was insistent that the only way to solve this problem in her life and get back to school was getting cleft lip surgery done. I spent numerous hours talking with Hasina about this. And we brainstormed multiple different options that she might have had in order to solve this problem, because her parents obviously couldn't afford this surgery. It makes me really proud today to say that Hasina actually chose an option to stand up in front of her class, call out the bullying, and request for respect. And she came back to school, she was in school, and today she's studying to become a nurse. As a well-intentioned Teach for India fellow, I was really left helpless. Neither the school management nor parents had the inclination nor propensity to pay to resolve issues that children like Hasina faced. And this often left us dependent on a handful of overburdened nonprofit resources, if at all we managed to secure parent consent. Which is why Sangat's POD adventures was such a breath of fresh air for me. Kids love technology. It really is no wonder that in their pilot program in school, Sangat actually found it hard to accommodate all those children who wanted to participate in the program. POD Adventures is a unified approach to problem solving that children can engage with over a smartphone or tablet. These devices are placed in schools by Sangat, and students use this app to improve their problem solving skills. Sangat's methodology actually works on a whole school level, with everybody in school and all young people as a philosophy. It helps to create an enabling environment for children to seek mental health support. They also work with groups of students to destigmatize counseling and generate awareness and therefore demand for counseling. Often digital innovations are created by the privileged few with the assumption that such innovations can be adapted for everyone. Sangat's POD Adventures, however, is different. It's been contextualized and is grounded in the reality of children from low-resource schools. Another problem typical of counseling in low-resource schools is that of drop-off. Children as schools tend to lose interest in the process, and therefore engagement rates are low. The POD Adventures app, on the other hand, is different. 93% of students actually completed all 4 sessions, and 97% of them reported that the methodology actually helped them in daily lives. The beauty of the POD framework actually lies in its simplicity. It's a 3-step approach to problem solving: problem identification, option generation, and creating a do-it plan. This is easy to remember and is a really functional skill that is easily replicable across the many scenarios that an experience. Inadvertently, that was something that I did with Hasina as well. We identified the problem, we generated options, and then she created a do-it plan. POD Adventures actually uses a graphic and audiovisual content about mental well-being. It addresses myths that surround counseling and actually provides a framework for problem solving, very easy to use and non-technical platform. I actually tried the POD Adventures game myself, and I was so pleasantly surprised because I was really engaged in it. It recreated so many situations that children often find themselves in: exam pressure, peer pressure, parents yelling at me. And as a protagonist in this game, I could navigate these problems and learn how to arrive at the most suitable solution for myself. It did leave me wondering, though, what would happen in those situations where children needed a little more support than was offered by the game itself. This digital innovation is bolstered by the non-specialist counselors who are trained in the POD framework. These non-specialized counselors come in to support children who might be in need of additional support or engagement. This actually allows children to explore issues on their own, but gives them the space to seek support. Learning of the success of the POD Adventures made me really excited about its potential for scale-up. However, limited human capital and the digital divide serve 2 significant barriers. Some aspects to consider include the gendered nature of the digital divide, where girls who are in more need of mental health support actually have limited access to technology devices. In one of the programs we run here at Swasti, we actually implemented the non-specialized counseling approach with Sangat, and 2 women from the community were trained to contribute to the counseling efforts in our schools. In a conversation with Sunita, who was one of our non-specialized counselors, I actually asked her whether her life had changed after she had started using this framework, or once she was introduced to this framework. And she said that it definitely, she actually has a 4-year-old daughter, and she told me that she would often get angry when her daughter did something wrong. Following the training and following the switch in mindset, she now just reprimands her daughter lovingly and explains why what she did was actually wrong. Hearing this actually makes me imagine a world where every parent is equipped with these skills and mindsets. Maybe we wouldn't need POD adventures then. Isn't that the goal after all? Over to you, Sri Rupa.
Thank you so much, Radhika. Just a very quick flag for Ben. Ben, I believe there have been multiple registrations which have come in my name. So just to stop confusions, can we just address that very quickly from the back end? I am just going to now quickly move the conversation on. It is important for us to also look at what can leaders achieve. And thank you so much for that, Radhika. And this brings us to a very interesting space where we move on from here. When we talk about leadership on the ground, right? And there are certain changes that can happen, which is phenomenally important for everybody at the last mile. And to talk about this or share this story, I want to welcome Dr. Vijay Shree. Now, Dr. Vijay Shree is someone that I call a true system innovator. She is a medical person. She is a doctor. She has also had over 20 years of experience in public health, and she's been working for bilaterals, for governments, you name it, and she has worked there, and sometimes also in very, very difficult settings. And she has been using her unique range of experience to really build together system innovation and make it work at scale. So over to you, Dr. Vijayashree. Let's hear from you on this story.
Thank you. Thank you, Shurupa, for the introduction. Namaste, everyone. I'm Dr. Vijay Shree. Yellappa. I work as senior specialist at the Health System Transformation Platform. It's a non-profit organization which is based out of Delhi. So the bottlenecks in the Indian primary healthcare systems are well known. Doctors tend to work under severe resource constraints, especially in the rural primary healthcare settings. Therefore, when you visit government primary health centers, you will invariably encounter shortage of staff, drug stockouts, lack of medical equipments, diagnostics, and so on. But today, I'm going to tell you a story of a primary health center which could surpass most of the systemic barriers, and it set out to achieve what was aspired in Alma Ata Declaration of 1978 to provide health for all. This PHC, situated in Nulpiya, Wayanad district, is managed by state government of Karnataka, which is situated in South India. It is ranked as one of the topmost PHC in the country by the expert panel of the Union Health Ministry, acknowledging its proactive, inclusive, and equitable approach toward delivering health quality primary healthcare services. So I would like to just give a brief background of the initiatives taken by Kerala government, which has long focused on health as one of their top priorities. In 1995, primary health centers were transferred to local self-governments to facilitate the decentralization. Another policy shift was to re-engineer primary health centers into family health centers, focusing predominantly on the people-friendly outpatient services coupled with community outreach. With this background information in my mind, I was curious to know how this primary health center addressed and navigated the systemic barriers, and it became an exemplar of comprehensive primary healthcare in India. The story unfolded when I met Dr. Muhammad Dahar, the medical officer of Nulpiya PHC. He had managed to achieve feats that might have taken a decade to finance and complete. This was mostly due to his ability to take alternative routes when faced with financial blockades, create innovative ways to engage with the community, and develop collaboration that brought diverse stakeholders to materialize vision of comprehensive PHC. So when I reached the PHC in Kerala, I saw a children park and a lush green vegetable garden in the campus of PHC, which was unusual in any of the PHC setting. The PHC team had very well realized that it was crucial to address the eating behaviors of the community rather than to provide a supplementation to fix acute malnutrition problem that was existing in the tribal community. A nutritional rehabilitation center was built in a separate building. A nutritious food was arranged for the patients free of cost through an NGO. This center was visited by a designated nutritionist who periodically assisted the patients and also gave training to the PHC team. And then I entered the outpatient department. This health facility looked more like a corporate hospital to me, so clean, with a well-lit, well-ventilated, and there was a help desk which was manned by a paramedical staff who were helping the patients to navigate the hospital. I was pleasantly surprised to see the PHC team had optimally utilized all the technological advancement to enhance the quality of care. Firstly, there was a digital system to generate a token so that patients need not stand in the queue. Secondly, all the medical records were digitalized. While this seems to be an arduous task in a tribal setting, it was contextualized by simplifying the processes wherein each individual reaching the primary health center was given a unique number which connected them directly to their medical history. While I was interacting with the lady medical officer in her cabin, a female patient entered into doctor's cabin with a token. Before the patient could enter inside doctor's cabin, doctor knew what is the patient medical history and what is the current illness. And it was displayed on the computer right in front of her. So as the patient entered the doctor's room, doctor greeted the patient with her name and asked how she's feeling. Patient could not believe that the doctor knew her name and all the medical history before she could narrate anything. For me, this was an example of patient-centric care and definitely a way to build a trust with the clientele. The next day, I had an opportunity to accompany the mobile health team and witness the outreach activity in a tribal hamlets. The PHC has a separate mobile health team which visits the tribal hamlets every week and examines the patients, delivers the primary care along with dispensing medicines. This team was led by an enthusiastic young medical officer. As we entered the dense jungle in the four-wheeler, all the people, the community people, elderly, children, women, all flocked around the doctor and the mobile health team. It was a visual treat for me to see the bonding and the trust the medical health team had gained with the local community. The team also had recruited some women from the community, and they acted as a liaising agent between the tribal community and the PHC team. I was watching how they could identify such women and how they have built the capacity. So this community volunteer came to the mobile health team, and she explained what kind of illnesses were prevalent in the community and what medications are required for the next visits. And I could see an immediate impact of this innovation was the visible reduction in the workload of the medical staff at the PHC. And the primary care was provided right at the doorstep of the tribal hamlets. I think this ability to address needs specific to the community and by understanding their context is what made this PHC successful and truly comprehensive in their approach. I realized comprehensive need not necessarily mean providing all the care under the sun, but it is providing what is required. As I was listening to the mobile health team and the medical doctor, I was wondering where all the funding was coming from. The most pressing issue when it comes to the government administered units, the first question everyone asks is, where does all the money come from? Supporting these lofty visions and ambitions is no small feat in tribal communities. and Nulpia team seem to be addressing every need seamlessly. When I posed this question to Dr. Dahar, the medical officer of Nulpia PHC, he replied with a short laugh and said, involving your stakeholders is all it takes. He had every strategy to involve different actors who had a stake in health. Firstly, in collaboration with the local government, he had mobilized tribal antenatal mothers to attend antenatal clinics. The local government had built cottages for pregnant women to stay with adequate nutrition provisions, which was provided through NGOs. A state-of-the-art electric auto rickshaws were arranged in collaboration with a local bank to ferry pregnant women as well as elderly to the PHC and sub-centers for checkups. For the outreach workers, the four-wheeler was procured through funds arranged through Member of Parliament. And then team had also mobilized philanthropic funds to build a physiotherapy unit in the PHC. The journey of this Nulpia PHC can be credited to the exceptional leadership of Dr. Taha Mohammed. This is an excellent example of how authority should think out of the box to come up with context-specific interventions to serve population needs. Nevertheless, the primary healthcare can work effectively when there is an accountability and trust with the community. I think Nulpia PHC has demonstrated how this can be achieved with intersectoral collaboration and community engagement. I'm sure the Nulpia PHC will continue to inspire Indian primary health centers' journey towards universal health care. I thank for this opportunity to share my story from the field. Over to you, Shri Rupa.
Sorry, I was on mute. So I was completely spellbound by your story. But thank you so much, Dr. Vijayashree, for sharing that beautiful story. We are going to keep this rolling. We are going to move on to our next story. And very interestingly, Dr. Vijayashree was talking about nutrition, and I am going to welcome right now somebody who has been a dear friend and a pioneer in nutrition and public health within our circles, especially in India. Vijayashree is somebody who has been working in public health, especially as a public health nutrition specialist with a career spanning close to 2 decades. And she's the ex-CEO of Foundation for Mother and Child Health and was previously engaged with various social development programs across India. She's also someone who is not going to stop herself from scolding you if she sees the wrong things on your plate. Just saying. Vijayashree has been, is right now the Director of Programs at Swasti, and I welcome her as the author for Get Well, Stay Well, Invest for Wellness. Over to you, Pia.
Thank you so much, Sri, for the really amazing introduction. And thank you, everybody, for having me here today. There's a lady who sells bananas just down the street from my house. And I meet her pretty much every day because I like my bananas. So I go and meet her and I pick up my bananas from her. I also see her around in the neighborhood. I bump into her in markets or in the local grocery store. A couple of days back, a little bit more probably, a few days back, I bumped into her at the medical store, which is in our neighborhood, where I kind of overheard her pleading to the pharmacist that, can you please give me a shot? My back pain is killing me. And the pharmacist was trying to explain to her that an injection may not work. And she was like, no, I need to get the shot because I need to get back to work tomorrow. If I don't, if you can't stop the pain, then I can't get to work tomorrow. Pay as you can and pay as you go is the reality of healthcare for the people who are vulnerable in the country today. Earlier in the beginning of the conversation, we were listening to Nisha's story, and she also says something very similar. She says that there was multiple illnesses in her family. Her husband couldn't quite work every day. He's not driver. Couldn't quite work every day because he had an eye issue. Until the time he got his surgery, he actually couldn't. He would only work 2 or 3 days a week, and now he just takes a day in the week off, and the rest of the time he works. I wish there were more such PHCs like Nutya that Dr. Vijay Shree is talking about, but we don't have that. What we also do not have, especially for the poor in India, is preventive healthcare. We do not have primary healthcare. We do not have continued care that they need. The cost of health for the poor in this country is often the cost of a day's wage or sometimes even more. And therefore, they're often left with pretty much no choice to treat themselves and their families at the time that they need. Forget prevention. That's seriously enough. And in this context, I found out about Invest for Wellness as a model that is being run at Swasti across about 4 different vulnerable groups: urban poor, rural poor, tribal population, factory workers, marginalized communities such as women and sex work. So what is IFOR? What does Invest for Wellness stand for, really? Invest for Wellness is a model that looks at not 1, not 2, but about 4 aspects that directly impact health for a family, an individual, and their community. One, of course, is physical and mental health, access to quality care, access to preventive health services. That is definitely one aspect. The second aspect is this whole financial piece that we're talking about, and you've heard over the Vijay story as well. If I do not have the money, I don't treat myself. I only treat myself what I can afford. So financial services is a very big aspect of how health is perceived and impacted for a family which is vulnerable. And the third thing is this essential aspect of social protection. When I say social protection, it means something very simple. If I don't have a PAN card or Aadhaar card, I probably cannot access any of the government schemes that are available to me, which are actually free of cost. It gives me, for example, the Matritva Suraksha Yojana, which gives me money if I'm able to deliver my child through, after completing the full health checkups and at a local hospital, right? I won't get that. Similarly, I might be earning some money, I might be okay financially, but my husband is beating me black and blue, and therefore my mental health is not fine. My physical health is probably also being affected. So if I do not have protection from domestic violence, my health is not going to get any better. So I4V essentially works for all these aspects. It also looks at wellness at the community level. So there are some things that an individual or a family cannot do on their own. So things like water, sanitation, hygiene, these kind of solutions need community action. So this is how I4V looks at these 4 different elements, brings it together under one umbrella, for lack of a better word, and the services are delivered to the members. Okay, so this is an interesting point. I remember talking to Shama Karkal, who's the CEO of Swasti, about usage of this word members. And what she says is that I4V or Invest for Wellness is not your regular welfare initiative. It brings together communities. It brings together families. It looks at challenges that needs to be addressed together. And since we all share the responsibility of our well-being, the ownership of this particular task that has been undertaken is also for ourselves. So therefore, we are members of this initiative and not beneficiaries as the usual word in this sector. So what does a member get when they're part of I4V? First of all, to be a member at I4V, you have to save about 50 rupees a week. That's about 200 rupees a month on a weekly basis. You save it with your local self-help group. You can have a group of 5, 6, 10 women who are your neighbors, and you kind of save with them, or there are options of being an individual saver as well. You do the savings. You have access to credit as well, financial services and credit. And the reason that we do not just do saving or credit and do both is because in microfinance, whatever my understanding of microfinance is, People also tend to save when they are taking loan, because I can take a small low interest loan from my from my immediate circle group at a low interest and pay them back, instead of me having to take money on loan from a local gold person, or or somebody who gives very high interest loans, and then end up paying them back forever, right? We also, so the IFRB members get savings service, they get loans. They also have access to other financial products like insurance. They also have access to preventive healthcare. So what does preventive healthcare mean? We actually do regular screening, testing for 20 plus high burden diseases, things like hypertension, diabetes, anemia, which actually have very long-term impact of no treatment or mistreatment on a family and an individual's health. The members also have access to the wellness center in most locations, where they have access to a nurse who can treat them for their basic expressions, like fever, a cough, injury, and that kind of treatment is also something that they receive. The members also have access to curated, contextualized, actionable information that helps them with their health and nutrition behaviors. Because you can, it is a very, I mean, I'm sure all of us know here that just pumping information to change a behavior doesn't really work. The information has to be actionable. And that is what a member at IFRB gets. The members also have access to the whole range of social protection services that help them navigate the social schemes, services that are available through the government, access to all the identity documents, your disability certificates. All of that is also something that the members receive. And this is and then finally, there is this investment of bringing together and building a community institution where there's a lot of energy and effort invested in developing leaders in the community, leaders who lead these community institutions, champions in the community who understand and then become the IFRB's brand ambassadors, who talk about the need to have a center like this, we need to have a system like this, and the need to be able to invest in your own wellness. So why is IFRB unique? I mean, what does it really give us? I think when I was leading to this whole case study that was being written and talking to Shama and also having experience on the ground, I think the unique positioning of health, wealth, and protection is what makes IFRB unique. The investment in community institutions, the investment in building strong community that actually takes the ownership of the whole community's well-being, not just individuals and not just families, is unique. But for me, the most unique piece of IFRB is how it is financed. Typically, grant funding is what we end up depending on for any intervention in the civil society, right? In IFRB, the way IFRB is financed is there are multiple layers and strategies that are being employed. One, the interest spread that the community institution earns from the saving and credit services that they provide is what supports IFRB. It actually supports IFRB financially. There are various health products that are offered to our members: menstrual cups, menstrual napkins, nutrition supplements, such as the Shakti leaf. A profit margin from that actually goes into financing this particular intervention as well. And finally, the other extremely unique piece of this entire intervention is the wellness facilitators. So for every 5,000 people, there are about 20 odd wellness facilitators who are women, mostly from the ground, from the communities, who come into this initiative, get trained, and go out there and actually make this entire thing happen. And thus, instead of having one group or one person hold the power of creating well-being for our community, it is the entire community that stays well, that gets well, and that stays well. I will stop here and I will hand it over back to Shruva. Thank you very much.
Thank you so much. I am going to now move into something that we are calling the listening circle. And thank you so much, Pia, for that. And if you can just move the slide, Nilakshi. So while Nilakshi moves the slide, I just want to convey that Shama sends in her regrets. She is doing a training for the municipal commission. Basically, we call it the BBMP, which is like a civil body, a government civil body, who are in the front lines of the COVID response in Bangalore, India, which is where we are headquartered. And Shama right now is on ground there doing the training, so she could not be here. I am going to request Pia to please step in for the listening circle. And Dr. Dahar, I am going to be spotlighting your video now. And I am also going to spotlight Patty's video. So this is just so that we have everybody here together. And can I request Ben to help me with the spotlights? I'm not being able to spotlight you. I'm so sorry. This is just strange tech stuff which keeps happening. Thank you so much, Ben. And can we have Patty on the spotlight as well? Patty, are you here with us? Sorry, Patty.
Hello.
Hi, Dr. Dahar. So sorry. I think we don't have Patty with us right now, which is such a bummer. It would have been great to also have her over here. But let's talk to you and Pia, Dr. Dahar. So Dr. Dahar, thank you so much for joining us today. And thank you so much for the incredible work you're doing on ground. So I'm going to start with thank you so much. I just have two questions for you. The first of all, how are you feeling right now?
Yeah, I'm very happy to have joined this program because I'm working in a remote area in Wayanad district in Kerala, and this out of our population, like 45% belong to tribal community. And we are the only panchayat in Kerala that we are sharing with two state boundaries. One is Tamil Nadu and one is Karnataka. And out of the total geographical area, 3/4 is covered by the dense forest area. So we are one of the remote panchayats in Wayanad district. And it was a big challenge when we're joining this institution to provide a universal health coverage to the entire people in this panchayat. So I'm very happy to share my experience here, ma'am.
Thank you so much, Dr. Dahar. I wish that the community and you stay protected. It is quite a very difficult time for us right now. Dr. Dahar, the next question that I have for you is more like, we would like to hear from you on your message for primary healthcare for universal healthcare. You've been doing some great work on ground. Dr. Vijayashree's story was so beautifully said. So, and it was your story. You're the protagonist. So please tell us about this one message that you might want to share with the community here and beyond on PHC for UHC.
Yeah, ma'am. Before starting, because one thing actually, because the people accessing the primary healthcare, most of them belong to the rural community. So to provide a quality care in a primary or anywhere in a community health center, we need support of the local government. It's a bit crucial here in Kerala because in Kerala Health Service, as we know, PHC, CHC, all are running by the local government department. So whenever every financial year we have to submit the project to the local government, especially looking after the health of the poor people in the panchayat. So whenever to provide a quality care in health service, especially for the tribal community and the poor people, we mainly focus on their need, and we submitted the project depends upon the care they need in the community. As ma'am told, like we have tribal mobile unit is running there. So as we know, tribal mobile unit want to go to the entire forest area. For that, we need a 4-wheel jeep. So we supported by the Rahul Gandhi, our MP, and providing the nutritional kit to the antenatal mother. We have a local government a project for purchasing of the medicine and other raw materials for the pregnant women, and provide the quality service in the hospital. We have one of the best laboratory services in our panchayat, and for purchasing of the laboratory equipments, everything. And the panchayat is providing different types of fund is available with a local government or a panchayat. So what we done is we mobilized the fund from this local government and utilize this fund in this primary healthcare, so we can provide a quality care. As we know, one of the example I'm giving to my entire population is, as we see any patient coming with a fever, if you go to primary health center, if you go to any corporate hospital, they are giving paracetamol 500 milligram. It's a common thing. But why then also people are going to, majority of the people are going to private corporate hospital? Why? Because they are not getting the mental health from the primary health care. That's the big difference we are facing now. So whenever a patient comes, they should be comfort with this hospital. And they should be feeling that this is my hospital, this is our hospital. This is the message I convey in my panchayat. So most of the people come to a primary health care in my community. And after last 3 years, when I joined this primary health center, our average OP was below 50. Now our OP was about 200. Now people are coming to the hospital, they're accessing the most of the services from our hospital. And when we take the feedback from these people, they're very happy because their daily expenditure, their pocket expenditure saving, because when they're coming to our hospital. So the message I want to give to the community is that make them people believe that this is our hospital and this is our services, then they will come to our hospital. Thank you, ma'am.
Thank you so much, Dr. Dahal, and thank you so much for your incredible leadership on the ground. And a big shout out to Dr. Vijayashree as well, and Nilakshi, who have been behind capturing these stories. So thanks a bunch. And I am now going to turn to you, Pia. Pia, you started out as an author for this story, and then now you are also on the other side as a protagonist, as the program lead and the implementation lead here. You have grown from being somebody who was on the outside looking in and looking at how I4V grew and was conceptualized, to ultimately then joining in and then just ending up with your feet on the ground, right? So yes, so let's hear from you, Pia. On I again have two questions for you. One of it is that how are you feeling on all of this coming together right now, and from the vantage point that you have?
Incredible, like you rightly said, I have known Swasti for a while. I have seen I4V as an outsider, and for me, I think it has been an absolute honor to be on this side now. So I think, which is why I was mixing up I and V and Swasti a lot in this, because I sometimes, it's a little difficult to kind of switch the hat. But it has been an incredible experience for me. I have seen the team. I have seen what's happening on the ground. I have met people, the community members, the leaders, and they're so inspiring. And this dream that I have as somebody in public health, that things will be okay one day. I just take that way on that path.
Wow, that's actually a shared optimism. As somebody also in the public health sector, I can tell you that that's something that keeps us going, right? Especially during these times. Pia, my last question to you, and my second and last question to you is: what is the one message that you want to give around PHC for UHC?
I think for me, primary healthcare and universal healthcare is not a dream that can come true unless we listen to what people really need and want, which Dr. Dahar's story tells us, which the Sangha story tells us, right? There was active and invested listening to what the requirement really is, and not come from a prescriptive perspective, right? I think that is probably the first piece. And the other thing that I feel that actually makes a difference is that instead of treating the community around us or the people that we're working with as somebody who needs to benefit. If you're able to share respect and dignity, and so if that community does not get the help that we need, then we cannot say we have achieved health for all, right? So I think that needs to be constantly reminded and thought about. And yeah, I think power in the hands of many has always been my dream. So I think that's the way we will achieve public health.
Thank you so much, Priya. And here's to wishing that you can democratize health for the most poor and marginalized for years to come. And thank you so much. And thank you so much, Dr. Dahar, as well, for being part of our listening circle. I'm now going to quickly move it a little forward. I'm going to bring back Dr. Angela Chaudhary, and Dr. Vijayashree. And I would bring them back talking to us about the journey forward. So let's hear from Dr. Vijayashree first, and then Dr. Angela. Dr. Vijayashree, I am going to be spotlighting a video now.
Yeah. Thanks, Shrupa.
Yes.
It was a wonderful session, and it was very interesting to listen to all the experiences from the PHC landscape. So we all acknowledge that primary healthcare is the cornerstone of the health system performance. So HSTP, the Health System Transformation Platform, recognizes the need for strengthening the primary healthcare, and it is investing heavily in this area by undertaking implementation research and also generate evidence for policy formulation and scale up of successful PHC models. The work that we presented today was made possible through funding and technical assistance from Health System Transformation Platform. Going forward, we would like to present this PHC exemplars to relevant policymakers at national level. In parallel, we have also commissioned a study to Institute of Tropical Medicine based out of Antwerp to undertake landscape PHC models from an international perspective. And we intend to compare this international perspective from our PHC exemplars that we have been undertaking in collaboration with Swasti. The another interesting piece of work undertaken by Health System Transformation Platform is in collaboration with Swasti team, who has undertaken a Herculean task of developing dynamic database of PHC innovation in India. So HSTP is committed to share these knowledge products with a wide audience around the month of September 2021 in collaboration with Swasti. We hope these knowledge products will facilitate the cross-learnings among the practitioners, academicians, and the policymakers, and help strengthen the primary healthcare and achieve universal health coverage in the region. Thank you so much for this opportunity. Over to you, Angela.
Thanks, Vijayashree. I just want to take a moment to summarize some of the insights that we had from the case series. There are about 10 insights. One, that no one primary health component makes or breaks the success of a comprehensive primary health model. It is the driver, the intersections of different components that helps achieve excellent results and health outcomes. Two, a successful primary healthcare system requires diverse owners, government, civil society, private sector, public and community leaders, along with bridges linking these actions together. This not only allows for CPHC models to provide for each community's needs, but also provides continuous care. All the models that are exemplars had made significant investments at providing equitable access. Task shifting and digital innovations have been a key enabler in making this a reality, particularly in resource-constrained environments. The successful models have had strong, consistent, proactive population outreach and responded to population needs, especially in the comprehensive healthcare models, and focusing on health determinants according to that need. Scripts, decision support systems, clinical algorithms have also been effective tools in maintaining consistent quality of care. Finding incremental ways in adding services that are missing has also helped make these models more responsive to the population needs and hasn't strained the existing system. Most of these exemplars have exhibited team-based care rather than a single professional, doctor or nurse. Sustenance seem to be directly attributed to diverse sources of funding. The community acceptance and ownership of primary health has ensured health outcomes, sustained health outcomes. Openness to innovation, learning, sharing, and application of learning set apart the exemplars from the rest. To address the gaps in knowledge and learning, and more importantly, to spearhead a transformative agenda on primary health in India, this was one such exercise. However, this is within an alliance of a comprehensive primary health care. It's called CPHC, with partners like HSTP, USAID, Asian Development Bank, the Bill and Melinda Gates Foundation, LGT Venture Philanthropy, and Swasti. It's envisioned as a neutral and multi-sectoral platform. The CPHC Alliance seeks a country in which everyone has the capacity to maintain health and well-being and are able to seek affordable healthcare when it's needed. Its mission is to catalyze collective action to achieve comprehensive primary healthcare in the country and region. So watch this space. This exercise could not have begun if it wasn't for the of Rajiv Sidanandan, the CEO of Health Systems Transformation Platform, and Shiv Kumar, the founder director of the Catalyst Group. These two gentlemen, who I've had the pleasure of working, are visionary and relentless in their pursuit of transformation of the primary health agenda. I want to thank all the organizations, Sati Sehat, Sangat, Nulpuria Family Health Center, KC Patti Primary Health Center in Kodaikanal, Institute of Health Management, IHMP Pachod, for sharing with us their valuable time and energies and invited us to experience their work in the communities. I would also like to take the time to acknowledge the team who's worked hard in the background, who you don't see here today, but are in this call, hopefully some of them, to bring you these exemplars. There are many more exemplars, and we can't begin to imagine how many more there are in the light of these significant challenges. And this is just the beginning of the journey for us. Sharing with you, my colleague, has been our links to all of these case studies. Thank you for having us. Over to you, Shree.
Thank you so much, Angela, and thank you so much, Dr. Vijayashree, for sharing with us and speaking to us. Thank you to all the authors, the speakers, the phenomenal team behind it, the team on ground, and of course, Catalyst 2030 for having us here. To kind of know more and connect with us, please do check out the links which are being shared on chat right now. Check out the stories, read the stories with even more detail and flourish on the links that were shared earlier. And look us up on social media, both HSTP and Swasti, as we will proceed to talk more and more about this, because we need to learn from these innovations to really tackle what is happening in the world right now. So please stay safe. Take care of yourself, wishing you well-being. And this is your host and your facilitator for the day, Shri Rupa Sengupta, signing off. Thank you. Take care. And just before you go, if all of you could switch on your videos, we could take a group picture, just saying. I can see some videos coming in. Thank you so much.
Maybe we should remove the presentation. That might.
Yes, let's remove the presentation. I'm going to remove spotlight from me as well, so we can all see each other. Can we please have the more people we have on video, the better this photo is going to be. Just thank you so much for all of you who are switching on your videos. Such a joy seeing you, and so glad that you could join. Okay, so I think we're just going to wait for like 30 more seconds for everybody to switch on their videos. I can see more and more people switching on their videos. Can we have more people switching on their videos? Great. So I'm just gonna Ben, can I request you to help us take these screenshots? Guys, a big shout out to Ben as well, who has been who has been phenomenal working with us to get this up and running.
Okay, I'm hoping this is gonna work. Okay. Nope, apparently not. Oh.
Okay, so I think I have managed to take a few screenshots. Thank you so much for switching on your videos. And thank you so much, Ben, for all the incredible support you've been giving. Big shout out to the team. Thank you. Stay well. Take care. Wishing you well-being. Bye-bye.